promise our mic will make its way around. Dr. Lutzer is again watching the chat online for any questions, and feel free to direct your questions to one speaker in particular or open it up broadly to the group. Go ahead, Director.
I am Tamara Connecticut. Several of you mentioned the need to invest in community. I actually study the other end of that spectrum. I look at older adults with long-term care needs. And I often end all of my talks saying we really, in order to sort of reduce inequities and improve access to care and improve quality of care for older adults, we really need to invest in communities, right? And so it's obviously this a huge, broad problem. So I'd love to hear from a few of you, especially those of you who brought that up in your talks, a little bit more about what that looks like, because that's a big that's a big task, right? And so it feels like if we only look at, if we have sort of very limited programs, it's not really move the needle on that very big goal. So I'd love to hear just a little bit more about what you really mean by that in practice.
I don't think I really understood the question, but the much that I got from the question, I think there is a benefit to the additive effects of programs. And you're talking about issues that we're all talking about issues that last for lifespan. Some of those issues we don't tackle them early, become a bigger problem at the end. But we need to build on the effect of multiple programs and programming. Like somebody said, when someone comes into the, sometimes I work with men who are violent, which is basically mostly. The issue is not often, a psychological bad guy thing. There are several other economic issues, social issues. Advanced childhood experiences are also issues that a lot of men, especially a lot of Black men, will address. So looking at these multiple factors and looking at the additive effects of the program, I think it's one of the ways to go. We cannot do it all from magic bullets, as we found out today, but building on the effects of programs that work, working at the grassroots level with community members, people who are most affected by these issues, is one reason.
It's a great question of what does that mean in terms of operationalizing these sort of big comments. And I think we do have a lot of programs that do invest in communities, right? Often what is missing is this idea of how can we get the community to work together to work on a common. And one of the things that the city of Chicago did really well during COVID-19, what other states have sort of built, is these health equity zones. An opportunity for the community to come together around a particular idea and have the resources to implement those goals. And to say that we will support the opportunity to kind of make that happen. And so what we did in this last budget was sort of try to build a framework of that. There have been other states that have been incredibly successful building these health equity zones. Rhode Island, a much smaller state, easier for Rhode Island to kind of put that into motion, but we're seeing some of those effects already happen with the state of Washington. And then also on our level, how do we use some of our own advocacy? And we spend it a lot on the federal level or on the state level, but part of the challenge that we have, especially around health and public health, is that local communities don't invest in it either. And often sort of the biggest things to cut. And if we feel like investing in communities, investing in the health of communities is critical, how do we sort of push that advocacy all the way down local level, kind of sustain it?
I want to bring it back to the housing and homelessness lens that I was talking about earlier. And so one of the things that the Department of Housing and Urban Development has been doing in recent years is funding communities to address youth homelessness through a mechanism called the Youth Homelessness Demonstration Program. And the purpose of this initiative is to have communities come together to engage in a planning process over a period of 6 months, where they develop a strategy for the community, bringing everyone to the table, folks from all different systems, all different programs, service providers, young people with lived experiences of homelessness. They bring them all to the same table, and they co-collaborate, or they collaborate and they co-develop the vision for ending youth homelessness. And then HUD promises to fund a certain array of systems, a certain array of services that the community decides they need to address this problem. And so I think for some of the other points that were raised, it's not just simply about having the resources or the money given to a community. Sometimes it feels like we throw money at things without a strategy for actually using it wisely. And so these YHDP initiatives are really, it seems to be, based on some of the emerging evaluation work, turning the tide in a set of communities that have received this funding. So when I think about investing in community, I think it's not just about the public resources that go into it, but it's about public-private partnerships and using all of those resources strategically.
I can add just that, if I have to pick one place where we will do that investment, that would be school. You know, we did it for physical health, and we could do the same thing for mental health, empowering school, funding school, getting school to be leading the way in terms of screening, education, decreasing stigma, implementing curriculum for, mental health. And hopefully later also being a place for intervention where we can provide intervention for problems that don't need to go to the healthcare system, kind of, saving that for people who really need more in crisis or the way we're providing them.
There's a question back here.
So my question is, as a mental health counselor, what is something that I can potentially work through or work on research wise that whenever I graduate, I'll be prepared to address these different health concerns? Because I do know race and things of that nature and economics do play a major role in health concerns, but how as a future clinician, how may I approach these different things on students?
I don't know if I heard the questions correctly, but we're talking about how you can implement some of the knowledge, learn about health disparity in terms of using that for mental health intervention.
Yes, like as a student on this level, like in person, as a future.
As a current mental health student or a student focusing on mental health, what can they learn now and what skills, knowledge, can they gain now that would help benefit when they enter the workforce to address the health disparities that exist in them?
I think understanding that if you're in mental health, you have to be in a team working with an interdisciplinary team. That's the part that draw me to child psychiatry. I enjoy being in the team. And you need to involve so many agencies and so many different services to address some of these issues that usually not going to be done in a visit, with your patient. And you need to be able to connect them with services, connect them with community resources. And then, some of my colleagues talked about the upstream of how we address some of these issues and, more higher level, like the policy or and not necessarily just the clinical work that we do.
One thing I would add is it's important to have a deep understanding of evidence-based programs. We find that lots of service providers who are engaging young people are not actually providing evidence-based services. They are providing some form of services or a program that they learned about or something they got online. We really don't know if those types of programs work. And so as someone coming up into this space, I'd encourage you to really try to understand those evidence-based programs, how you facilitate them, especially in the domain of counseling and mental health therapy, and so that would be my, that would be my advice.
Well, first, congratulations on your career pursuits, going into something incredibly beautiful and noble and something incredibly difficult, challenging on a day-to-day basis, right? And I'd say just sort of two things that as you think about this from a educational perspective, and I think great advice here. One, that your patients are going to be your guide, right? They might not always have this sort of detailed knowledge that might come from some of the experts, but they're living and talking to you from their experience, right? And that ultimately is the biggest sort of set of information that you need to try to get their lives better. And then to try to figure out the right kind of strategies and whatever evidence-based ways to kind of take care of yourself in these very sort of demanding professions. We know how hard they are. We know the incredible burnout. And I think it's makes me smile just to know that there are dedicated folks like you still continuing to study these important disciplines and going out in the communities to make a difference.
I want to also add that a lot of people who come into this helping professions usually come to those professions because they have a history. You know, a lot of violence providers often have had abuse happen to them. And just like the last speaker said, in terms of self-care and taking care of yourself, we need to heal ourselves to be able to heal other people. And I'm talking to myself too as well. We have a lot of baggage and a lot of things we come in through. You know, we're trying to get the grades, we're trying to graduate, but then we move quickly into practice, and we still have those issues that need to be resolved. Something else I wanted to add, research at my forte and to a lot of fellow students, and you need to figure out what methods and methodologies best work for the population concerned. So we've gone beyond talking about the good old-fashioned theory of planned behaviors and other wonderful theory to using a critical, more radical lens to investigate some of these issues we're talking about. There's enough issues, it's been around for a long time. But how do we adapt with the times? How do we get the community members to trust us again? How do we mend, broken relationships that have happened over the years? It's not easy to say, as a student to go find these things out yourself. Sometimes someone teaches these things in class, but it gets to a point where you need to figure out what your toolkit looks like, right, for the population to work with, and develop that on that.
I'm taking the next question. So this is from the chat. For Dr. Vohra, from Latoya Gregory, how can community organizations gain access to the funding for mental health programming?
So the one that we just announced, this 9.5 million, was a competitive grant set of applications that we announced a few months ago. I think one of the things, and so if that notice of funding opportunity did not reach your community-based organization, we apologize for that. But I think it has been some sort of our intentionality. As we said, we kind of covered 40 different organizations. That one thing that we are actively sort of working on in government is to be able to make sure that people understand what's important. And that's not perfect, right? I'll admit there that we don't have the best tools, and especially public health didn't have the best tools to be the kinds of marketers that we needed to be able to not only transmit educational information, but opportunities moving forward. So this specific funding opportunity is now closed, but we'll continue to kind of make efforts, and happy for us to get some contact information afterwards and follow up so we can make sure that your organization continues to be on our mailing list.
Another question over here.
My question is, Is there any research or any information, that we received back regarding, I guess the way that, the pandemic has caused a change in telehealth and now embracing that? I'm wondering, with the youth, that are tapping into their counselors through the internet, telehealth, and things of that nature, is there a difference in it, or is it just personal preference, or are we embracing that, or is it something that, you know, what do we do with that information, or do we have any on that?
So I did talk a little bit about, violence and substance use and how racial and ethnic minority adolescents pivoted to telehealth modalities. Telehealth is not new, but it became an absolute necessity at that time when people were locked in. But of course, some problems arose, having to use telehealth, insurance coverage for that kind of support. The digital divide, I talked about how 99% of our sample have smartphones, but a lower percentage have access to broadband internet. Also, when young people especially are reaching out for help, oftentimes they do it in homes where there are issues. We have some parents who, in the violence prevention world, who monitor browser history, right? We have some parents who control Wi-Fi access, which means they control the access to resources they do not get in school. So some of these issues have there to play up. And then we have, a fundamental lack of Black and Hispanic therapists who have access to telehealth as a modality to reach their patients. And so what we have, like I said, and I do apologize to my therapists in the room, but when the young Black men are telling us they do not trust therapists, and it has nothing to do with race or gender, it makes a case for the promise and the usefulness of this kind of modality for that population. For the smartphone app, they love it because it's discreet, it's closed in, it's private, it's confidential. But when you're talking to someone over a video conference call or over the phone, they have expressed hesitation with that form of care. So there are issues with it, although, to be honest with you, the benefits outweigh the cost.
One of the things, the good things that came out of the pandemic was the expansion of telehealth for mental health. So I can tell you, our department continued to do 75% of our visits over telehealth, primarily because of the preference of the patient and their families. We have a new rule now, having to bring some of the patients who are on Schedule 2 medication, like stimulants, to come at least see us once a year in person. And many of the families don't even want to come for that one visit. So it's a huge shift. It also made us expand now because, physical space is not as important as it used to be. So we have, we hire people, but they don't have an office per se, they share offices. So it definitely changed how we deliver services. Did it change the stigma to some extent? But, I agree that there's still work to do there.
So I, as you all can see, about rise in anti-trans rhetoric, whether it's in the classroom or elsewhere. So I was wondering how that has affected your funding and also conceptualizing programs that you're doing. And also given that there is a need and an output of to identify as students, how that affects funding. I think the question was how the rise in anti-trans and non-binary rhetoric has affected the way we work. Okay. I would say in the work that we're doing with young people experiencing homelessness, we've long known that members of the queer community are more likely to be rejected by their families and to face social marginalization more broadly that's associated with their likelihood of becoming homeless. So I would say for us, I mean, I don't think it's necessarily like changed our work over the past few years. We've moved more into the space of trying to think about, this, a project that we do related to reproductive and sexual health care for young people who are systems involved, or sorry, who have systems involvement or who have experienced homelessness. Like a lot of that work has shifted more into thinking about how to expand gender affirming care and how to create resources for service providers who are working with young people who are members of the peer community. So I would say, the way we work hasn't changed, but we are certainly like more attuned to that issue. And I feel like as folks in the youth homelessness space, we're sadly kind of waiting for the information to kind of come down the pike as to what has been the impact of some of these anti-trans and anti-gender affirming care policies in certain states. And I'm sure that there will be information available soon to understand exactly how that has impacted young people's mental health and their risks for homelessness.
And I would add that that there are efforts across the state of Illinois and through, again, the governor's leadership, and is never shy about stating over and over again that Illinois is an inclusive state, in Illinois where we want everybody to show their true authentic self. From things that we're changing in our vital records around different kind of designations to the programs that we have in place. I think the challenge, and this is more on an operational level than a policy level, is that it's hard to get people times to engage. And what has been our challenge is try to build the programs to find the individuals that need help, and working with a number of community health worker coalitions to really try to get health workers out in the community to engage, show individuals where they can come to organizations that are welcoming, where they can get their care. And it's been a place where it's harder to engage in the regular healthcare delivery systems, but trying to open up opportunities for community health workers to be the nice bridge and individuals that are also trans or part of the LGBTQI+ community, to make that outreach from a trusted source to get them to engage with the services that they need.
We know that, hate, anti-trans sentiment has consistently increased over time. It's unfortunate that we're still trying to get a clearer picture of what the problems look like. We're still trying to do our descriptive statistics to figure out how much this is a problem. But we're not focusing on the solutions quite yet, because to be honest with you, a lot of people do not know what to do. And this is because we don't have trans people in the room helping develop interventions and helping chaperone policies as well. I think that's a really good place to start in addressing some of the issues that are going on. In violence prevention world, I see some of my colleagues having to retrofit some of the things they had done in the past to work with trans youth and LGBT and queer youth as well. And they're going back to make sure that we're including and being inclusive of this populations in the interventions that we design. But, like I said, we're still trying to get a clear picture of what the problems look like. You saw from some of the data that I showed today that even, the CDC, the World Health Organization, we're still collecting binary sex data, male and female, for research data collected even as recent as 2022. So at that level, we need to start addressing some of the programs and having more nuanced breakdown, to be honest, of what this populations are experiencing.
Thank you so much. This wraps up our panel. I realize it doesn't wrap up all of the questions that individuals have, and we always run out of time. So for those of you that have questions, feel free to come up afterwards or reach out. Thank you again to all of our speakers and all of our panelists this morning for a really rich discussion on youth mental health crisis, but also the potential ways out of it and what's happening in Illinois and also nationally. One last round of applause for the group.
I also want to just thank all the speakers, an amazing series of talks that are all interwoven together actually in terms of themes and concepts. So the conversation will continue at lunch. Each of the speakers will be at a table. I think Vohra unfortunately will not be able to join, but please continue the conversation at lunch. At the back of your book, there's a QR code. Please scan that and complete the evaluation survey if you can. It helps us plan for next year's event. So please, that's very valuable information for us. Please exit through the back door to get to the lunch, which will be out here in the atrium. And please join us for a poster session where we'll be seeing posters and then that's giving out awards for the top 3 posters at the end of the session. So thank you for all of you for coming. It's been amazing. So many issues to address, so many problems, but some promising solutions, I think. Both in terms of practical intervention and also in terms of policy. So amazing to have all that at our disposal to move forward. Thank you very much for all of you for coming today.